So, good morning, Coalition. It's great to see everybody this morning. And we've got some more people coming in, but that's great. And we've got a couple of things to share with you about upcoming information. And let's see, I think Kathy's going to share a little bit.
Good morning, everybody. Well, this is an unusual month. As you know, the 1st of October was on a Friday. So next week is a coalition meeting again. So coming up very, very quickly, and our executive committee will be meeting the same week. But we're looking forward to seeing all of you there. And there will be a regular newsletter out with all the opportunities that are out there for people to participate. So keep an eye out for us.
So there's our update. All right, so let's just get right into it so that we get the maximum amount of time with Dr. Kent here. So Erin, so great to have you with us this morning. And we've got a lot of things in common, it seems. So tell us a little bit about where you grew up and your family and the covered wagon coming across the country and all of that.
Thank you very much, David. So I grew up in California. I'm actually I've lived there most of my life. I've been in North Carolina for 4 years, and prior to that, outside of DC for about 7. But before that, I grew up in Southern California in Orange County. I'm now in Orange County, North Carolina, but I was in Orange County there. And the covered wagon reference is that I'm actually 7th generation Californian because on my dad's side, I think my great-great-great-grandfather came over sort of prospecting for land in the early 1800s. And wow. we have a journal still. Somebody typed it up, about 7 years ago. So the pages are kind of falling apart, but we have a journal that he kept. And then my family were farmers for many years until my dad kind of broke that tradition. But yeah, that's where I'm from. But I love being in North Carolina, and I've now become a true Tar Heel. So go Heels.
Absolutely. So, and your family settled in the Salinas Valley, you said, and I know the Salinas Valley well because I spent a number of years at the Naval Postgraduate School in Monterey, which is just on the ocean side of the Salinas Valley, and I actually lived in Arroyo Seco for a while. I don't know if you remember where that is, down near Greenfield. So lots of things we found.
Small world.
Common, yeah. So then you went to school. You went to Berkeley for an undergraduate, and if Allison is listening, I don't see her on here, but Allison would be very interested that you started out with a specific degree at Berkeley, and that was?
In psychology. So I was a psychology major at Berkeley, and at the time, I didn't even really know that much about public health. There wasn't a public health major. I knew that it existed, but I didn't really know much about epidemiology or those kinds of methods. And actually, following my undergraduate degree, I was very interested in animal behavior, and I ended up getting a master's degree in animal behavior and did a lot of work with bottlenose dolphins, actually, for my master's thesis. And was very interested in the social behavior of dolphins and how they did a lot of caretaking and social support and the pretty innovative methods that we could use to study them, which was actually primarily taking pictures with high resolution photography. At the time it was film, now it's all digital, of their dorsal fins, because the trailing edge of their dorsal fins typically have distinct notches in them. And so over time, you can identify individuals in a population by going out on boats and taking pictures of them and sort of constructing a social network of how they affiliate. And so that was really fun and also hard work. We used to joke that, for every hour in the water, you're spending 4 hours in the lab. looking at and tracing pictures of dorsal fins. But following that, and actually as part of that work, we did some capture and release programs as well in the Indian River Lagoon in Florida and in estuaries in South Carolina to try to also get a sense of the health of the populations. And it was really interesting to see differences even in those two fairly close geographically locations, that the dolphins would exhibit different kinds of health, sometimes problems or health characteristics based on the water quality of those water systems. And that's what kind of brought me back around to being interested in epidemiology and public health. And so following that, I went to UC Irvine to the School of Social Ecology and got my degree, and which has a concentration in epidemiology. And that's where I got interested in cancer research and trying to think about supportive care and social support in general for cancer patients and their families. And so following that, I went to work at the NIH at the National Cancer Institute, where I was for about 9 years total before I came down to UNC.
That is fascinating. So what's the connection that you would most tell us about between your study of the ecology and the development of animals like bottlenose dolphins and humans, especially as they perhaps get cancer?
Yeah, so I think that what has been remarkable to me throughout that time, going back to talking, my mom still is a practicing psychotherapist, and so I had a real penchant for psychology and thinking about just relationships in general. And then doing the work with the dolphins really kind of helped affirm for me how social so many beings are. So, obviously we know that humans are social, but dolphins are too, and they develop relationships with one another, not just in terms of those that they're, directly related to. So obviously we would expect that mothers and calves would have a bond, but males would often go and find other males around sort of the same age and spend a lot of time, a disproportionate amount of time with them, fishing, hunting, defending against potential predators. And sometimes they would sort of leave those relationships, but then come back to them. So we would call that a fission-fusion society. And it just, for me, I just think it's so interesting to see how the relationships that we have play so many different roles in our lives and are so fundamental to our survival and our thriving. And so when we think about illness, right, we think there's been such great work over the past few decades centering patients and the experience of illness. And so you hear patient-centeredness all of the time. And I think there's now sort of catching up recognition that illness happens to families, right? When a member of a family system, a family of origin, a family of choice, whatever it may be, a closely bonded group of people, it's like a pebble in a pond. It has this rippling effect on everyone. And so we have to continue to widen our aperture on illness experience, that it is a social experience, and that we need to continue to develop practices and policies that recognize that fact.
That is so insightful and so relevant for particularly this group. Man, that is amazing. So you've probably found this whole experience with COVID both terrifying and very illuminating. Are there some lessons that as 600,000 people dead have been surpassed now in the last couple of weeks that you would find and maybe give us some thoughts about?
Yes, I'm speaking to a very well-informed and committed group of people who are all, I think, still processing and still working, many on the front lines of all of this still. I mean, here, I don't think anybody thought in March of 2020, or, you know, many of us probably didn't think that we'd still be in the trenches of all of this. I think that there have been the tragedy is almost hard to put into words in terms of the lives lost and the long COVID and the sequelae and the all of the economic impacts, all of the trauma for people who have experienced either loss of life in their communities or big economic impact of COVID, the social isolation, the lost schooling time and lost peer time for children. I mean, it's profound, and I think it has just sort of forced so many different sectors in our society at various levels to reckon with the fact that we need a lot of attention to new design of so many of our systems, whether it's healthcare, education, the workforce. I mean, in some ways we've realized that we can do things differently, right? I mean, I've never met most of you in person, I think. We've had these amazing monthly coalition meetings where we've all had the opportunity to fairly conveniently connect to one another. And, I'm looking at so many members of the Caregiver and Patient Engagement Work Group, and I feel very close to. And that's all been happening, I don't know that it would have happened exactly this way if we hadn't had the circumstances that led to, the need for social distancing. So, I think telehealth has become a real possibility, and I think that needs to be continued. And I think it's also shed a lot of light on the impact of illness on families. Right? We continue to get reports of studies that are coming out about the impact of visitor restrictions, and so I think that's another opportunity that we can learn from and sort of redesign around.
That's very, very thoughtful. Thank you.
So Erin, you and I talked for a couple of minutes before we got started about social support, and I know you've started some new research in that area. Can you talk a little bit for this group about where you see that kind of research going and how particularly it relates to the work we're doing with seriously ill people?
Sure. Thank you. Thank you, Catherine. I think so. Our team at UNC. So I'm in the School of Public Health at UNC, and I collaborate with a psychiatrist in the Comprehensive Cancer Support Program. Her name's Dr. Lisa Park. We are working on an adaptation of a social support and navigation tool specifically for caregivers of cancer patients. So we have the great fortune of collaborating with a researcher named Dr. Maya Reblin, who is a social psychologist at University of Vermont and has developed this tool. It's essentially, it's a program that's comprised of both a self-management application or a web application or tool called that helps generate what's called an eco map, or essentially helps caregivers identify and visualize their informal support network, helps them sort of like expand their notion of who might be able to help provide both the caregiver themselves, but also their care recipient in all of the domains of support that we might imagine. So not just necessarily emotional support, which sometimes is the first thing to come to mind, but also things like instrumental or practical support, like helping deliver groceries, helping pick up prescriptions, and informational support, so helping perhaps decipher medical jargon, and financial support, helping really advocate with health insurance companies, and sometimes helping find charity support resources. So lots of different kinds of support that we can all imagine if we take the time to really map it out. That tool that Dr. Reblin developed is now paired with a navigation program. So the intervention that we're working on would be an 8-week intervention. So with weekly calls and this tool designed to help reduce distress of caregivers who are accompanying a care recipient through a recent cancer diagnosis. And we're calling it Encompass. Right now it's Encompass Carolina. And we have about 3 years of support from the Duke Endowment, for which we are very, very grateful, to both adapt this tool for our population in North Carolina and test it with about 180 caregivers across the state.
You're fascinating all of us here. This is amazing stuff. And I see Sue Collier has a question here. She says, love the EcoMap approach. Assuming that the coalition is on the map, what could we be doing to support or foster or bolster the support systems for patients with serious illness?
So I would be remiss to say that I think everyone here in many ways is already doing so much. So I would just say, carry on, warriors. And I would also say that the more that we can bridge build as within our coalition and make sure that that we all can support each other in our work, and I think that's a big goal of the coalition. I think is important. And I mean, I always talk about, it's research implications. How can we do a better job studying this? It's clinical care solutions, sometimes small. I mean, our cancer center is trying out creating name tags for caregivers to help them recognize that they are a part of the care team, to much bigger, things like helping to advocate for actual financial resources to be provided to caregivers when they need it. So it's the small and the big. It's I think increasing awareness of the role, the invaluable role that caregivers play in serious illness. It's all of it, right? I mean, I think that we have so much potential here. I think to do so much for our state.
Absolutely. No question about that. My mind is just is looking out at all kinds of things here. One of the goals, as you know, that we've had for some time is to change the laws around advanced care planning, and we're hopeful that that'll happen fairly soon. Advanced care planning is sort of a discrete event. It's a document that gets filled out by somebody. We're hoping to make it so that people don't have to have a notary and 2 witnesses, but a notary or 2 witnesses. But then we want to be able to upload the document to a registry that the state will create and make it an electronic approach, and the Secretary of State's office, Ann Elmore, has been very engaged with this, as has the HIE authority and so forth. But I think the social support network that you're talking about would be a critical part to integrate into that whole approach of advanced care planning. Is there something that we can do to facilitate that and to work with you more closely?
I could imagine an opportunity for some sort of dialogue as our team continues on with our adaptation process. So I will put in a plug that I may be calling on some of you to get input into this process and make sure that we have, in addition, we are working a bit with NC Care 360 to help populate resources on the back end when people need to have a set of customized, but a set of resources that are out there and that are actively available to support them and their loved ones. But this group is so well informed and resourced that I would love to, as this project continues on, to solicit some input from all of you. So thank you for that.
Yeah. I mean, I'm seeing there's other folks that are are making similar comments in the chat here, like Keith Starwald. He said, let's help revision advanced care planning as a running narrative, with advanced directives being part of the superstructure of what you're really describing there, so that we have an integral capability to move all these things forward. And then, Catherine, did you want to say more about what you were thinking?
Yeah, when I think that when I hear the word social support, one of the things that I get very excited about, but also concerned about, is that first of all, we don't all recognize where our social supports are. And then we don't have a lot of skills necessarily to ask those people in our world for help in a way that we can actually get what we need from our network. How do you see the kind of work that you're doing helping to enhance that? And what should we as a coalition be doing to enhance that communication piece of this, so that social support network works well for that person, for that seriously ill person?
Thank you for that question. I think that, in working with Dr. Revlin, we've come to the notion that although a self-management tool it can be hugely beneficial, it's really not enough. That to make this as effective as possible, we really need a combination of navigation support with the tool. And so as part of the program, we have designed, and again, we're continuing to iterate a bit on the design, but sessions to actually help people understand that support is multifaceted, help develop effective ways of asking for help from that network, and then recognize that it's very normal and important to be able to ask for some help, and that it doesn't have to be something that is any way diminishing of an individual's own capacity or own self-efficacy. In fact, if anything, it should be something that is built upon, and support seeking needs to also be seen as a skill that we lift up in the individuals and families that are going through illness. And so, there's oftentimes like models of, and I've seen this more applied in grief and bereavement, but I think it works in the context of serious illness navigation, which is this idea of like layers of support. And so when the support comes in, the dumping goes out, right? So the person who has the illness should be the most protected. The persons around them who are that primary support buffer, or those primary caregivers, also need support so that they can do the work of supporting their loved one with serious illness. So it kind of should be a layered impact. And a lot of times I think, helping organize a support network of carers is what the community often wants. They hear about somebody being, becoming diagnosed with a serious illness, and they want to help, but they don't always know how. So sometimes it just it takes some level of organization, and sometimes some level of gatekeeping to help kind of keep that support matrix in place. And there's a lot that the healthcare delivery system and team can do to help foster that and help work with that, so that there's clear pathways and roles for all of those people involved.
Excellent. So, Erin, tell us something that we might not know about you that you've shared so far.
Oh, goodness.
Put you on the spot here a little bit, but what you spent 9 years at NIH at the National Cancer Institute, and your work there has informed what you're doing now, but what's some of that we need to know about?
Yeah, I think that, I'm primarily a researcher. I'm now an educator, and I feel really passionate about that, about getting to work with the students that are just so exciting and bright and committed at Carolina. But, I would say that sometimes I think the federal agencies that we have that are supposed to represent our interests can feel very remote and removed. And I understand why it feels that way, but they really are staffed with people who are committed and trying their best to try to embody the mission of their agency and support people like us and networks like us, researchers and clinicians and policymakers like us. And so I think that I would say, having been a program officer at NIH, try reaching out to whatever federal agents that might represent your specific interests are, and try to do some bridge building that way too. Because, I was able to get a funding opportunity announcement developed and passed for the National Cancer Institute that's still active, specifically to create interventions that support cancer caregivers, right? And we had a meeting, full of people very much similar to our coalition membership, come together in 2015. I think we were able to fund 15 people, 78 people came, just to talk about the state of the science in cancer caregiving. And from that, we put together an announcement that ended, to date, I'm probably a little bit out of date, but it's funded at least, I think, 15 or 16, large scale NIH grants. So we're talking about, the R1, right, is that sort of that typical grant. So that's anywhere up to about $2.5 million, just to develop and test and implement interventions to support families going through cancer. So I think that there are ways to, I think, make cases to people who are in agencies, in the Beltway, who are trying to do good work. I think it just requires some persistence sometimes, and being opportunistic also. But there's a lot going on with RAISE right now. Let's see if I can do this. Recognize, Assist, Inform, Support, Empower Act, through the Association for Community Living. With that report now going to Congress only about a month ago. So I think there's a lot of opportunity to, I think, move the needle right now with supporting families and going through serious illness.
Mm-hmm.
That's great. We just saw a little bit about the RAISE Act and the RAISE initiative, and I see Karen Appert shaking her head yes. So I would be remiss in the last minute. Your boss's boss up there, Dr. Francis Collins, just announced that he was stepping down at the end of this year. He is a UNC grad, or at least he got his medical degree here. Any thoughts about, what that means and conjectures about his replacement?
I don't have any conjectures about that, but I think we're all indebted to his leadership for the last, he covered 3 different presidents. There generally is good bipartisan support for NIH. And, I think we have big shoes to fill with Dr. Collins leaving. But I have a lot of hope and confidence in the Biden administration to, appoint someone who can carry the torch for the years to come. And maybe, who knows, maybe it'll be someone from our fine state. Maybe it'll be a Tar Heel. That would be fantastic. Ned Sharpless, who's the director of the NCI, is also a Tar Heel as well. So we'll see what the future holds.
Absolutely. Well, Erin, this has been fascinating, and there's several other questions that I think you sort of answered, but we don't have time for right now. But I know people are going to be picking your brain after all this. This has been amazing. Thank you very much for your role in the coalition and for sharing part of your life with us today. It's been great.
Thank you so much, David and Catherine, for having me today. And just thank you to all the members of the Caregiver and Patient Engagement Work Group who came and everybody else. It's really lovely to have this interest. And I would love to get a copy of the chat because there's so many great comments that I would love to follow up with you on. But please always shoot me an email. I'm on the membership directory, or just erin.kent@unc.edu. Thank you, everyone.
Thanks so much, Erin. We'll get you the chat.
Take care, everyone.
Have a great weekend, everyone.